572-0383 or 572-0215. REV-UP St. Lucia, the alpha of radio.
Doctor in the House brought to you the compliments of La Place Salazar, Dalcan Pharmacy and Tapio Hospital.
At Tapio Hospital, caring and competent obstetric consultants will see you safely from prenatal care through delivery with a team of excellent pediatric and anesthetic support. Tapio Hospital, where the patient safety comes first.
Looking for affordable, reliable healthcare? Visit Dalcan Pharmacy on Coral Street, Castries, where your health comes first. We carry a wide range of over-the-counter and prescription medications, all at unbeatable prices. Plus, enjoy special discounts on prescriptions for kids 12 and under and seniors 60 and over. We offer supplements, body braces, skin care, feminine care, and oral care items, topical creams, and more. Plus blood sugar monitors for just 40 EC, 50 test strips for only 50 EC, and blood pressure machines at affordable prices. If what you need is currently out of stock, we're happy to place specialized orders just for you. Need advice? Check out our private counseling room. Visit Dalcan Pharmacy on Coral Street, Castries, opposite the Magistrate Court, or contact 572-5282 or 720-1655 for more information. Dalcan Pharmacy, your health is our mission.
It's delicious.
La Place Salazar is the true home of quality meat and deli products, selected and priced to suit every palate and pocket. We sell all cuts of meat, poultry and fish, from tasty lamb necks and succulent pork chops to lean dolphin and juicy top round steaks. Our deli items include turkey, ham, bacon, pork sausages, meat patties, chicken nuggets, deli ham and eggs, so that breakfast or that party is a breeze. And for your added convenience, we sell restaurant essentials and grocery items. So where's your next meal coming from? La Place Salazar, of course. La Place Salazar, Castries, Groselet, Beaufort, and Soufrière.
It's delicious.
It's now time for Doctor in the House, live on REV-UP St. Lucia 95.9 FM with Dr. Leonard Surage. Dr. Surage, a very good evening to you.
Good evening, Andre. Good evening, listeners. Welcome back again to Doctor in the House. Today, I will be introducing one of my medical specialties that we have not actually said much about. And it is the role of the anesthetist as it pertains to pre-operative assessment, meaning that before your operation, you need to be assessed to see if you are fit for the operation in many ways. We do blood tests and things, but there is a specialist that you hardly see. Usually you see him or her before the operation, and then at the time of the operation you may see her again, and you have a brief exchange. She tell you what she's going to do, or he, and then you have the anesthesia, and then you don't know what happened. So you never, unlike a surgeon or a gynecologist or a pediatric, there is a long, you see them over and over and over. The anesthetist plays a different role. So the anesthetist basically would be the one who will be looking. They're not only there to put you asleep, they're there to do other things like ensuring that you're safe, ensuring that you can stand the operation. For example, apart from him putting you to sleep, they see about your safety, they see about your health, your pain control after the operation, and your immediate recovery after the operation. So the anesthetist does all that, but we generally just encounter them for a brief moment. So an anesthetist is a professional, a doctor who has done the basic doctoring program and have gone back and specialized in another area called anesthesia. Some training hospitals have a 3-year program, some may have a 4-year program, that kind of thing. So 4 extra years you spend only doing anesthesia, only putting people to sleep and wake them up and all the services that surround that. But in terms of every day seeing your doctor, you hardly see these people. And their role is extremely important. For example, an anesthetist would be, before the surgery, it's important to see them. They might do a blood test to find out if your body can take the operation, or if you can take the anesthesia, because the anesthesia itself has complications. They would, and anesthesia can be delivered in several ways. They can give you a mask, and the mask have the thing drift you to sleep, and they can do their procedure and so forth, if it is a very small procedure. Or they can paralyze you, take over your breathing, and take over all your bodily function while you're having your operation. And when the doctor says that the operation is finished, then they reverse everything. And they wake you up. But the thing is that you never fully remember the amount of time you spend sleeping. Because if you go and sleep tonight and you wake up after 4 hours, you pretty much know that you're woken up before the regular time, and you may not know how many hours, but you know you have not slept your full time. But with anesthesia, you can be there for 15 hours. When you wake up, as if you just gone in.
Yeah, that is true.
So anesthesia have that effect. Anesthesia also, in putting you to sleep, they paralyze your muscle, because for them to give you the tube to breathe, they must paralyze your muscle so that the machine can make your chest move. Otherwise, all your chest will be stiff and air can't get in and out. So they have to paralyze you for that. And the paralyzing agent, some people can be allergic to it, but they have their way around that. And that's very uncommon. So anesthesia have its effect. Sometimes people complain that when the tube is put in their throat, it leaves them with a sore throat afterwards. But that usually take care of itself. And also the air that they put in is usually humidified, and it carries the halothane or whatever agent it carries to keep you asleep. So they have to know, the anesthetists have to know that all these that you can tolerate it. Also, they have to make sure that some major things are in place. For example, if you're hypertensive, they have to make sure it's controlled. If you're diabetic, they have to make sure that the diabetes is controlled. If you have kidney problem, they have to make sure. If you have respiratory problem like a pneumonia or whatever, they have to know. Because when they give you the anesthesia and they breathe for you, they are pushing oxygen into your lungs and take up carbon dioxide in the same way that you breathe. However, when they're doing that, you're not awake, so you will not know, they will not know unless they measure your oxygen level exactly if you're accepting all of that. So if you have a cold, or if you have a pneumonia, or if your lung is not working properly, you will not be able to maintain that level of oxygenation that's necessary.
So, Dr. Surage, at what point does all this checking take place? When does that happen?
Well, usually, if I am going to, say, book an operation for you, apart from doing my part of it, I'll give you a note and do some blood tests and tell you, go to the anesthetist. I'll arrange an appointment with the anesthetist for you. And you will go, on the appointed time, you'll come with your blood results, or he or she may have it from the computer. They would have, whatever information I think the anesthetist need, I would give it to you, you take to them. And they'll look at your blood, they would look at the hemoglobin. The hemoglobin, which is the richness of your red blood, is important because that's what carries oxygen. And if it is low, then the oxygenation will not occur the way at optimum, the way it's supposed to be. But not losing sight of your question, so the appointment will be made for you, and you will see that anesthetist. You may see the anesthetist a day before, a week before, and so forth. We really don't want it to be too long, like 2-3 months, because things might change in the interim. So yes, so
so-
you will see them before.
So that's if you know you're going to have surgery.
Yes.
So what about those instances where, for example, you go to the hospital and the doctors assess you and they say, wow, okay, surgery next morning.
Well, that is because you have a condition that is severe enough that cannot wait
Right.
more than 24 hours.
So,
Okay.
so all these checks I was asking you about,
Yes,
what happens there? Because
so in an emergency setup, the anesthetist will, at its earliest convenience time, go and visit you before the operation. They would, even though, if you could be more urgent than that, you can have a serious problem and then you are in casualty. And the anesthetist and the surgeon say, from casualty we go straight to surgery. The anesthetist would come to casualty, look at the patient. Or if he or she doesn't do that, they'll ask you to come to the theater. They look at the patient, look at everything, and if the blood is so low or there is something that is so off, the anesthetist will now tell the surgeon, look, can you wait a little longer while I make that person fitter for surgery? Because at that moment, I think that it's going to be dangerous for us to proceed.
do these protocols, are they always followed, Dr. Surage?
Well, as far as I know, yes. It may not.
I laugh because I know when I was at the hospital, when I had my surgery, I never saw. All I know, if there was an
Anesthetist.
anesthetist, look, I'm actually having trouble pronouncing the word now.
Yeah.
If I saw one, was when I actually ended up in the operating theater. At that point, they tell you that they're going to be putting you to sleep and so on, that sort of thing. So as to whether it's an anesthetist, I'll go check.
Yeah.
I'll go check the pronunciation in just a little while.
Anesthetist. Anesthesia.
Yes.
Okay, the Americans call it anesthesiologist. That might be easier.
Anesthesiologist. Yeah, I think so. Yeah, so again, I don't even know if it was an anesthesiologist who was actually there at the time when I was told that they're going to put me to sleep.
Okay.
Because I came to the hospital the night before, and by the following morning I was told, you're going into for surgery, which I did not even expect. So that's why I asked you, are these protocols always followed?
Yeah, well, as far as I know, because there are situations, of course, where the doctor who is going to be dealing with you, the surgery, would have told the anesthetist all what she wants to know. That your blood pressure is okay, you have no diabetes, you have no hypertension, your medicine is well controlled, you have no bleeding issues, you don't have this and that. So basically, have informed him or her, the anesthetist, of all these things.
So when you're about to have the surgery and the anesthesiologist, well, I'm assuming, is he or she the one always there to put you to sleep, or the doctor has the power to do that?
No.
The one who's doing the surgery?
The one who's doing the surgery is the surgeon, and his job is to do the surgery.
Okay, not...
He is not equipped to put you to sleep. Now, having said that, in the older days where we had no anesthesiologist, the surgeon, and you have to be put to sleep, the surgeon would have initiated that and let an assistant maintain the breathing while you do the operation, because left alone you die. So, but in modern times, the anesthetist is the one doing it. They may have an assistant that assists them, but they are they have the chief responsibility for that.
Okay, so I understand what you're saying.
Yeah.
So, Dr. Surage, I'm curious to know, what is it that they actually administer to the patient that knocks you out like that? Because I was just probably playing the fool with myself at the time when I said to myself, you ain't putting me to sleep now, boy. And I'm saying to myself, I'm not going to fall asleep. I'm not going to fall asleep. I was saying so, to myself. Just having some fun. Joke you making.
Joke you making. I tell you that the amount they'll give you, if you're going to be dying by lethal injection, no matter what you think, you go in.
That's true. That's really true.
So, an anesthetic agent is the same agent for pain control. The amount and the concentration will shift it from giving you pain control to anesthesia and to knock your knock your brains, your consciousness level into a deep sleep, and also affect your breathing. So it does all that, depending on the amount. Because you may be surprised that the same medication they give you to sleep is the same medication that's used for severe pain for people who have cancer and things. Yeah, so it goes from pain control, sedation, to anesthesia, to total paralysis. Now, when the body is paralyzed, say you give them a high level of anesthesia and the brain is knocked out, they are asleep, you have to breathe for them. And then you put a tube from the mouth, sometimes from the nose, into the throat, through the vocal cord, and you put a cuff on it so that secretion from above the tube will not go into your lungs.
Mm-hmm.
And having secured that tube in place, then you can ventilate the person. They have ventilators that will give you the amount of air you need, the volume of air you need, and the frequency of which the respiration must go. Usually 15, 18 times an hour, a minute. So these things are part of being put to sleep. And of course, when they are waking you up, all the medication they give you can be reversed. So they have medication that reverses it, blocks it, and the reversal takes place. And
so just explain to us then. So in this unconscious state?
You're unconscious
state. So you're saying when the surgery is over, the anesthesiologist again, or the doctor administers some
doctor administers nothing.
Okay.
The surgeon, his job is to cut you open, take what they have to take out, put what he has to put in, close you back, and he and his team.
Right.
And out of courtesy, he might, and if he's experienced, he might tell the anesthetist, I expect to finish in the next 15 minutes. So if they were going to give you a bolus of a medication that will last for half an hour, they may decide, hold back, let whatever is there begin to wear off.
So while the surgery is ongoing, this anesthesiologist is still there?
Sitting at the top of the table all the time.
Ah, okay.
Now, there can be occasions where the anesthesiologist is not by the head of the table, because if he or she has a reason to be outside or dealing with another person for a lot of problem outside, he can put everything on automatic, have one of the nurses or his or her assistant to look at the parameters, and he can step out, not out of the theater itself, but out of the room, and then maybe take a conversation, take a telephone call, whatever. But at no time they're supposed to be outside any distance away.
So the doctor tells the anesthesiologist the length of time the surgery may take?
Yeah, when you're planning the surgery, before that you plan. And in fact, there is something called the WHO, the World Health Organization protocols. So first of all, before anybody do any operation, before the operation starts, you say, well, get the attention of everybody and say, the patient on the table is Mr. Joe Blow, 48-year-old Mr. Joe Blow, and what operation he's going for, then the surgeon will say, and how long you expect to take, the surgeon will say, how much blood you expect to lose, the surgeon will say, and do you have all the equipment you need for that operation, the surgeon will say. Then the same person turn to the anesthetist and say, do you have all the things you'll need to do the anesthesia? Yes. Are there any critical steps that you will take that we don't know? No. Everything is routine. And is there any equipment that you would want that we don't have on the table? No. And then they say, are you ready to go? Yes. Tell the nurse, are all your stuff sterilized? Yes. Have you consulted with the doctor to find out what equipment you need? Yes. And you have all your equipment? Yes. So, people, time to go. We start. And they ask you which side you're operating, left or right.
So the surgery is just about over. Say that the doctor realizes maybe another 10 minutes.
Yeah.
the anesthesiologist is there now to either apply some more,
or
administer more of the,
or whatever it is, or if whatever he's going to administer will last about half an hour, he or she may decide to use something else that's a shorter duration, so that when the patient is finished, the anesthesia is finishing to tidy up the two. It's a skill.
So there's no administering anything else to get you out of the.
Yeah, sometimes if for example, patient was beginning to get stimulated and getting a sign of getting awake, and you give them a bolus that normally lasts half an hour, and in 10 minutes they say, well, I think it's time, I'm about finishing. He cannot wait half an hour for the thing to wear off. So there are other anti-drugs that will combat the effect of the first one, and they apply that to reverse it. They call that reversal. So you can fully understand how much training that anesthetist must have in terms of therapeutics, in terms of medication, side effect, all this kind of thing. So they are usually well trained in that area.
So who's the person that says, wake up, wake up? Is that the anesthesiologist again?
Yeah. Wake up because they want to stimulate you. They're not being rough or rude, or if they give you a little tap, it's simply because they want you to wake up on your own as much as possible, rather than drug you again to wake up.
All right, so I got it that far. So let me ask you another question, Dr. Surage. Why is it now, when they're wheeling you in to surgery, you have this, I don't know.
Your clothes.
Yeah, what do you call it? You have
the gown.
Okay, the gown. You have a gown.
The one that they apply to you back to front.
So you know it then.
Of course.
You know it very well.
Yeah.
Right, so back to front. So you going in there and you have no control over what you can do at the back. Okay? So why is it that way? Because sometimes, I'm sure, right, you're probably exposed there.
Well, that is, it may seem embarrassing to you, and it ought not to be that the person is totally exposed. It is that if you have an attire that is opening up from the back, you can get to the hands. If you want to put an IV line, you can take it off and put it. If you want to change the other hand, if you want to go to the chest, wherever you want to go, you can just lift up the gown and you have it. And so that is why, for accessibility, they have it this way. So you can easily get to a hand, get to an arm, whatever.
You can also get to the private parts as well.
No, well, when you're operating...
You know why I said that, Dr. Surage?
Yeah.
Because people talk, you know.
Yeah.
People talk.
Yeah.
And people say exactly what is it that they saw.
Well, yes, so, but it does not mean that there is an indecent exposure. The person,
that's what you call it?
Yeah, well, because when you're operating on, whether it's man or woman, the area you are going to operate on is the only area that's exposed. Everywhere else is covered. But
that's not what I heard, Dr. Surage. That's not what I heard.
No, what I'm saying is that if a person went out of their way and begin to squeal about what they saw, well, this is unethical.
No, this is St. Lucia.
Yeah, no, but it's unethical. And
whether or not it's unethical, Dr. Surage, it happens.
Yeah, I don't know the extent to which where you're going with it, but what I'm saying is that you say you don't know where I'm going with it. I'm telling you. They tell you, right, what they saw, what they didn't see. Yeah, but it is not when you are.
And I'm sometimes saying, but how could these conversations be taking place right there in the presence of a doctor, right, who's having surgery? Because they have these conversations taking place.
Well, I can tell you, of all the 40 years or so I've been operating, I've never heard any discussion about somebody's private area being discussed openly in theater. I just have not heard it, and but because I know that if you're operating on somebody, it's like we do the thyroid. We have no business. The person may come with the gown that in going from the trolley onto the bed may expose something. But I mean, this is not, that's inevitable. But you don't concentrate on that and stuff. But as soon as the life cover them.
You may not concentrate
Yeah, but
on
I'm
that.
saying that it's more of an aberration than actually an aberration of behavior than what is accepted and standard normal. Just like you say, the standard driving practice is this, but a man will drive twice that speed.
Mm-hmm.
But the point is that it is more of an irregularity. This is not supposed to be the done thing.
Well,
You have to, we learn from ethics. The person's exposure is sacrosanct, and you preserve it. You don't leave them open just because the patient is not seen. According to the ethics of the profession, ethics of theater, exposure is limited. Now, if in between somebody sees something they didn't see, and they decide to talk about it, but that's different. It's more,
just letting you know.
I know you might have
It
things.
happens.
And,
it does happen.
So that is.
I was just curious to know what was the thinking behind this gown thingy,
Oh yeah,
which is a lace or something, and it's at the back.
it's for easy access.
Mhm.
Putting in the front, you can't put the thing in the front because you want your front to be covered.
Mhm.
Okay, so if there is a slit, it is better to have it. Some places have it on the side, and but most of the gowns are done so I can tie for long ribbon, so you can pull the ribbon out.
So if a person wants to, can they go in there with their underwear or something like that? Or
Well, most people go with their underwear. But however, we say that if it is a nylon underwear, we tend to tell you, take it out, because the nylon can conduct electricity. And if when you are operating and say you are burning a little vein somewhere in the thyroid, the electricity passes through the whole body. And then you can get scars from burns from the groin area. So for that reason, if it is cotton, yes. And if it is not the area where you're working on, for example, in gynecology, of course, you'd have to move that. But if that's not the area in question, you're allowed to use your undergarments.
Okay.
Yep. So the anesthetist job is very, very important, and I think it is the reason I'm raising it now simply is because it is something that we tend to overlook. Because if you ask the average person the role of an anesthetist, they may not be.
In fact, I never even knew this person was actually in the operating room.
Oh yeah. Well,
I just thought it was just the doctor, the one doing all the administering this thing that knocks you out and so on.
Oh no. The anesthetists have their own big machine. They have their ventilator. They have their anesthetic machine that brings in. They can monitor the oxygen, monitor the carbon dioxide, monitor the pulse rate, monitor all kind of things. And you had a beep beep beep. It's not for the surgeon. It's for the anesthetist. And sometimes the surgeon will be working, and the anesthetist will say, "You all have dislodged my tube." Looking at the reading, realize that the tube was disconnected, go back and replace it. So they monitor everything about that patient at that point. And so the anesthesia usually is made of an agent that will either numb you, put you to sleep, and then use other medication to wake you up, to reverse that thing. Now, the thing they look for the anesthetist is whether your high blood pressure is controlled. Because if you have, and that's how they can cancel the operation. So when somebody has an operation that's been cancelled, they feel very upset, very angry, etc. But it is because either the surgeon or the anesthetist have seen something that if they were to proceed, the patient might be in danger. Okay? It could be that the pressure was too high, and maybe the pressure control. Because sometimes the patient will tell you, my pressure is controlled. You go in the clinic, you do a blood pressure, not too bad, and something has happened. Maybe a few months has occurred while they're on the waiting list. And by the time they got again, the pressure got higher, and the anesthetist decided it's a risk.
Well, now that you're talking about it, can you explain to us how the blood pressure now would affect the outcome of the surgery?
Right. The pressure, if it is high, then it means that the pressure in the veins, the arteries that supply, is higher. It will bleed more because you have more blood flowing. And bleeding causes a lot of staining of the tissues, and you don't see the different tissues as well because all of them are stained. Number one. Number two, when you have high blood pressure and you take anesthesia that will lower the pressure, when you are waking them back again, the pressure tends to rebound, just like electricity. When they take the current and you put it back, it comes as a big pulse.
Yeah.
So that pulse can give you a heart attack or it can give you a stroke.
Wow.
And that's the more dangerous part of it. And so that is why we are so fussy about that kind of thing, the pressure and so forth. And similarly, if you have diabetes, we would like it controlled, because diabetes make the post-operative recovery more difficult. It may also make the recovery slower because of the immune system. And so therefore we try to control your sugar as well as possible. As you know, diabetes adversely affect healing at large. So that is why you want to get it as controlled.
So would the same apply to if you have cardiovascular issues as well?
Yeah, if you have ischemic heart disease, cardiovascular disease, the same thing. You don't want to stress the heart too much since it is already diseased. But of course, having said all that, there is always that situation which happens often where the patient have to have the surgery. You can't leave somebody dying and bleeding just because they are this and that. So it is what you consider the better of two evils. And medicine is riddled with these kind of scenarios. It's always a hard decision you have to make, especially as surgeons. You have to make tough decisions. Do I go or do I not go? Can I wait a day or should I not? If I wait one day, how will the patient worsen? How will the situation improve? All these balances is something that is a daily occurrence to you.
Okay, Dr. Surage, we have to take a break.
Yep.
So when you come back, you'll open up the lines.
Thank you very much, sir.
Okay, this is Doctor in the House, live with Dr. Leonard Surage, brought to you the compliments of Laplace Salazar Dalkan Pharmacy and Tapio Hospital.
Tapio Hospital Radiology Department offers 24-hour service. We provide you with X-ray, CT scans, and ultrasound imaging using the most modern equipment that produces the best images for your medical attention. Call the Radiology Unit at 459-2201. Tapio Hospital, where the patient safety comes first.
Looking for affordable, reliable healthcare? Visit Dalkan Pharmacy on Coral Street, Castries, where your health comes first. We carry a wide range of over-the-counter and prescription medications, all at unbeatable prices. Plus, enjoy special discounts on prescriptions for kids 12 and under and seniors 60 and over. We offer supplements, body braces, skin care, feminine care, and oral care items, topical creams, and more. Plus blood sugar monitors for just 40 EC, 50 test strips for only 50 EC, and blood pressure machines at affordable prices. If what you need is currently out of stock, we're happy to place specialized orders just for you. Need advice? Check out our private counseling room. Visit Dalkan Pharmacy on Coral Street, Castries, opposite the Magistrate Court, or contact 572-5282 or 720-1655 for more information. Dalkan Pharmacy, your health is our mission.
It's delicious.
Laplace Salazar is the true home of quality meat and deli products, selected and priced to suit every palate and pocket. We sell all cuts of meat, poultry and fish, from tasty lamb necks and succulent pork chops to lean dolphin and juicy top round steaks. Our deli items include turkey, ham, bacon, pork sausages, meat patties, chicken nuggets, deli ham and eggs, so that breakfast or that party is a breeze. And for your added convenience, we sell restaurant essentials and grocery items. So where's your next meal coming from? Laplace Salazar, of course. Laplace Salazar, Castries, Rosalie, Beaufort, and Soufrière.
This is Doctor in the House live on REV-UP St. Lucia with Dr. Leonard Surage. Dr. Surage, is back to you.
Thank you very much. Are you going to open the line?
Yes, of course. Definitely. We're ready. Just give the numbers. Or should I do that for you?
You can do that for me.
All right. The fixed line is 572-9710, 572-9710. Or you can WhatsApp 287-0971. WhatsApp is 287-0971. Again, the fixed line 572-9710 or WhatsApp 287-0971. Okay, you can call now.
Thank you very much, and thank you, listeners, for remaining tuned, and we'll continue our discussion. Remember last week I told you I did something on a patient with a cancer of the throat, etc., that kind of thing. And one of the issues I have, and it comes back to the same thing we're talking about, preoperative assessment. And when we decided that this person will need a tube because they can't maintain airway.
Sorry to disturb you, but we have a call.
Oh, okay, all right.
Just, try to recall your thoughts.
I'll remember my trend of thought.
All right.
Hello, good evening. Thank you for calling.
Hey. Good evening, Andre. Good evening, Doc.
Yeah,
good evening, sir.
How are you doing?
How are you, Doc?
I'm good, I'm fine.
Okay, fine, thanks.
Right.
Thanks for accepting my call.
Okay, good.
You're welcome.
So.
Yeah. Okay. Yeah, Doc. That's a nice. Yeah, it's so nice to come with this topic there. I went through that already.
Oh, you went through that already?
When I was, I remember they put the needle on the back of my hand. Yeah, and then they tell me, okay, put me to bed. Then I remembered the lady came because she expect me to sleep at a certain time. But
you're a tough guy.
I'm saying to myself, if you believe I sleep, I have to see what you're doing.
Say the same thing.
Yeah.
So that's a common thing. Yeah.
No, but imagine in my eye they did me the operation. Yeah. So so I remember she came. When she came by me, I heard she say, "Oh," and she came back. She came with a small tablet. That's the smallest tablet pill I ever seen. Yeah.
Okay.
And she gave me that. I drank that, and I don't remember anything again until she woke me up.
Okay.
Yeah. And then let me ask you, though. Is there the same person who the
anesthesiologist
thing?
Anesthesiology.
Yeah. Everybody is different. I mean, does she have something, or do they have a monitor or something to monitor that this person who is about to operate on there is fully unconscious? That when they cut, that if they cut you, that you don't wake up or you don't feel the cut?
The cut. Okay, many people say that they were not fully asleep when operation was done. They can paralyze you and they can anesthetize you. Usually they anesthetize first and paralyze after. But there have been occasions where the anesthesia component may have been weaker and the paralysis was there. So you can hear sound, you can hear things, but you're not fully asleep. And some of them feel, some of them don't.
Okay.
So
I remember.
yes, so they have to wait until you're fully asleep, and they look by. There are a few things they look at. For example, your eyelids, the pupil would change size, and the eyelid, the eyelashes, when you irritate it, it does not cause a blink. So these are the deepest signs of anesthesia, and they have the other ways of doing it too as well.
Okay, because I remember I went to extract a tooth when the dentist inject me. When he now you stay around 5 minutes or so before he extract the tooth, and then when he come to extract the tooth, as he put the pliers or whatever thing, I had to freeze it away because like the thing didn't dead. I mean the gum was in numb. So then he had to come and give me another injection.
Okay, all right.
Now, two things. So that's why I asked.
Right, there are two
when
things.
You put
there.
your sleep.
There is putting to sleep to anesthetize you called general anesthesia, And there is local anesthesia where you inject a small area and work on that area. Now, the local anesthesia work on the fact that it prevents the nerves from carrying out sensation and pain. And so it numbs it. And therefore, they can cut, they can do everything, you don't feel it. It could be that the anesthetic agent was either too weak or too little. And therefore, you may have felt it when they were doing it.
And then,
it's
Doc, and then the last thing, Doc, before they put me to sleep, she asked me whether I have dentures. I'll listen on the radio. I don't know why she asked me that, and so I'll listen on the radio.
Thank you. Thanks for calling.
Thank you very much.
Night.
Very good question, as usual. Yeah, usually if they're going to put you to sleep, and if they're going to put a tube to breathe for you, they would have to go through the mouth. And the thing they use to, the forceps they use to raise the tongue, find the voice cord and push the tube, if you have dentures, it may affect it. And so that may be the reason why they ask him about dentures. Also, if I'm going to do operation like using a rigid scope to remove things in the lungs, etc., the front teeth are always at risk, because when you bend your head down, you're trying to create a straight line from your mouth to your lungs. So you have to bend that head right back. And in doing so, if you have loose teeth in the front, you have a problem. Similarly, children who are like 6, 7, 8, when they are shedding their teeth, you have to be careful, because if you're doing tonsil operation on them and there's a loose tooth, if it is very loose, you better remove it. Because in working and putting the gag, which is the blade that actually allow you to see the tonsil without you holding anything, when you apply that, it rests on the front teeth and you can dislodge it. But not only dislodging it, it can dislodge it and it can enter into the lungs without you knowing. So that's why you're very cautious about that if you have any loose teeth and that kind of thing.
So going back to the issue of pain and sort of deadening the pain for the moment, because if you're under general anesthesia, you're not supposed to feel the cut and things like that.
Yeah, that's right.
Right? Okay, so let me ask you, is that the reason when the surgery is over and the anesthesia wears off, that there's this rush of pain? Is that why?
That's right. Yeah. Because if you apply local pain medicine, it has a half-life, meaning that half of it would have disappeared or less effective, and when the pain will step in again. So what we do sometimes, what the anesthetists do sometimes, is that when they would also give you pain medicine, either suppositories or IV, that can last longer. So when the local pain disappears, the other pain kicks in. And that's why the pain control is there. And of course, they can't give it to you by mouth, so they give it to you by vein. But there's one thing I had forgotten to tell you, to mention. You may wonder why they're always so keen on putting a drip for you. They always, whatever, they want to put an IV line. It is because, for one thing, if you are going to have anesthesia, you say general, you would have been fasting for more than 6 hours, 8 hours. If you're going to have operation in the morning, usually by 10 o'clock the night before, you don't eat. So that's at least an 8 hour of fasting. Operation is at 8, so another 2 hours, 10 hours of fasting. During that time, you have lost some fluid, because your body sheds fluid all the time through urine, through breath, through talking, perspiration. You lose fluid at the rate of 2 liters a day. So you have to replace that fluid. And so it's not unusual that you would have been a bit dry by the time they're doing the operation. So you have to have the fluid to maintain your fluid level, because your body, your immune system, everything works better if you have fluid on board. And so it is not out of mission state that they want to put the IV line. They have it, they have access. So if they can put the anesthesia through it, if they have to control anything like pain control, this, that, or whatever, they can put the medicine right through it. And medication by the vein works much, much faster than if you were to drink it or if you were to rectally to put it.
Why is that?
Oh, because in the vein, that is where it eventually will go. So if you drink the tablet, it goes in the stomach, melt in the stomach, taken by the blood, then it circulates. But if you have direct access, it's much faster.
Understood.
Yeah. So that is to do with the... What I was saying earlier on is, you remember I was telling you that there's a patient that needed emergency putting a tracheostomy, a hole in the in the windpipe to secure their breathing because breathing was cutting up. In a particular situation, the anesthetist would have seen that patient and have decided that the growth is too much covering the vocal cord, and there's no way putting that patient to sleep to be able to put a tube in. You'll not see where the windpipe is. So we had no choice but to do it without putting the patient to sleep. And so that is one of the things I was saying about to preserve life. You have to make some hard decisions to be able to do. And of course the patient was very upturned and very restless. But you have to calm them down and do what you have to do.
Dr. Surage, I'm curious to know whether you've ever encountered anybody, maybe in old or very old age, maybe 80s, even 90s, somewhere around there, who had never had a surgery in their life.
Yeah.
You come across those people?
And they say, Doc, that's the first time I am having any operation. Yeah. And they have managed for a long time. And usually these people they may have illnesses that could have been healing faster but didn't, and because the natural healing always takes longer. And so, but if you intervene with medication, it goes faster. But yes, they have had situations like that.
But do you think it is inevitable that one day the average person will need some kind of surgery?
Not necessarily, because if we believe that about 80% of what happened to us is preventable, and if you do from growing up, if you develop some good habits like not overeating, exercising, keep lean, sleep properly, and all the little things we say, and eat a balanced food, and brush your teeth, check often, most time not much goes wrong. Apart from the little flu that you get by exposed to other people, you might break a leg, whatever, but generally you can do quite well for quite a while, but not even, I'm not saying not visiting a doctor, but not having to have operation. Yeah. So
are there people who you know who have had their appendix up until death?
Many people.
Yeah?
Oh yeah, many people. Appendix, yeah, and tonsils too, till death. Never had it worked on. But things like unlike adenoids, appendix, you really don't have much choice. It's not anything you do differently that causes it. It's just luck. Because you can't say, if you don't eat this, you'll not get appendix.
Right.
Because the appendix is a little piece at the end of at the beginning of the big intestine. That little bit is an appendage that has about 1 inch to 1.5 inches long, and it's attached to the large bowel, and it's just there. And sometimes it gets infected. But the appendix have no particular use. It is, scientists believe, it's a remnant from old development of the bowel from other animal kingdom.
Really?
Yeah. To allow it to, as things evolve, things begin to happen.
In my case, because I had mine removed.
Oh, okay.
Yeah, and man actually had
you were infected?
Yeah, gangrene.
Okay.
It was actually gangrenous. So that's why I had to have it removed. So it was really bad.
Yeah, and in fact they say if you go and remove the appendix and find it's not at fault, you should still remove it.
Really?
Yeah. 2 reasons. One, that you're already there, it's a likelihood it might give trouble at some point. And 2, and even more important, is that if you have an emergency situation in your belly and somebody see the appendix mark, the scar, and they don't have your history, they'll say, but what's that? The appendix have been removed already. Why should that person get that? It couldn't be an appendix problem. It was removed.
I see.
So for these 2 reasons.
But I remember when I had that issue, I did a lot of research and I couldn't come up with anything. I know for sure in the case when it's gangrenous, right, that it's very rare for that to happen. That's what I read. And as to what the cause was, science doesn't seem to know.
Gangrene, okay. The gangrene is because it has lost all its blood supply and it is rotting away. That's gangrene. Okay. Now something can block because the appendix, although it's 1.5 inches long, 1 inch, it's a little bit of intestine, tiny, and it has a lumen or inside have the little passage like ordinary bowel. That passage can get infected. It gets infected and it was not taken care of immediately. It cuts the blood supply and the rest begin to rot. That's all.
You make that sound so simple. You have another call, Dr. Surage.
Hello.
Okay. Yeah.
Hello, good evening. Yeah, go ahead.
Thanks. Yeah, Doc. Thanks for accepting my call.
Yes,
Doc.
ma'am.
Yeah, two things, Doc. I remember in my surgery, and I want you to explain for me.
Okay.
When she woke me up, she told me to breathe harder. Yeah, I don't know for what.
Oh,
yeah. To breathe hard.
Because sometimes after they have paralyzed the muscle and they have taken over your breathing, when they leave it out on you, your brain gets lazy. You don't want to breathe, too much effort. Because it was done for you all the time. So they have to stimulate you to make you take a gasp and to start your process again.
Oh, okay.
Yeah.
And then
and in the same way, like you remember in children, babies, when they come out, they usually give them a little slap because you want them to start breathing on their own, and the stimulation give them a gasp.
Okay. And then the other one, I had this this water, this thing there.
Yeah, your life water.
That life water.
Yeah.
And the nurse told me like I have to be going to the bathroom to urine often. And she told me it's important and that I have to be, I don't know for what.
To go to the bathroom often?
I remember after this operation, for the night, there was somebody with me. I went about 20 times about 10 times in that bathroom urine. I don't know for what. So
okay, well,
I'll listen on the radio.
Okay.
Yeah.
Thank you.
When they give you the fluid, I don't know if it's for dehydration or what. When they give you the fluid, it is directly in your blood system. So it's not like drinking it is much faster. So it gets to the kidney faster and the kidney produces urine faster. So if you up the fluid, increase the fluid, and your kidney is working properly, then the extra will just go in the kidney. But it's important to have the kidney working, because if the kidney is too slow and not getting enough water, the kidney can shut down, and that's another set of problem. So to be on the safe side, they may have actually give him a little more fluid, which meant that he would have to go to the washroom more often. I'm not sure if 20 times is a good thing, but then.
You have another call.
Yeah. Hello, good evening.
Hello, good evening, Doctor.
Good evening.
Good evening.
Nice to hear you.
Great program as usual. You answered most of the questions I had.
Okay.
But I was just curious. Do you consider giving birth as a surgery? Because sometimes they give you some anesthesia as well for pain.
Okay. Right. Unless you have a cesarean section, it is not considered an operation in that way. In natural childbirth, is not considered a surgery.
Mm.
Although they do have a little surgery with it, because sometimes when the head is passing through the birth passage, there's an area where it is very tight, and you do what you call an episiotomy to open the birth passage a little bit. So the outer part, they make a small cut, and usually after the child has come out, they sew it back. That's the only surgical aspect of it. But if it is natural birth, it's not considered surgical.
You say if it's a cesarean.
If it's a cesarean, because the cesarean section is when they cut the skin on the belly and get to the uterus and cut the uterus and remove the baby and sew them back.
So that's considered
a surgery.
Okay.
Okay, so I hope that clarifies for the lady. Yeah,
I must admit, our listeners are asking some very interesting questions.
That's
very
right.
interesting.
The kind of things that we take for granted.
That's true.
And that's the idea of the program, because many little nuances that they have can be explained.
Yeah, one of them is that I didn't realize that the anesthesiologist is actually in the operating theater at that time. I just thought it was the doctor doing the surgery, and I see some nurses, and that's it. Yeah, that's important. That's very important.
Yeah, because that's why when people are looking at cost of operation, I would tell them there is a cost that the surgeon charges. That's in the private sector. There's a cost for the anesthetist, and there's a cost for the hospital that provide all the services. And so we have to be mindful of that, because when you say things are expensive, and these are not communal garden thing, everything has to be sterilized, and every sterilization has to have proof of sterilization. And there's a certain paper you wrap around. If you're going to have a set of equipment to sterilize, after you seal it, you wrap a paper on it that when the paper has met the right requirements, the amount of heat, the amount of time, the temperature, it will change color.
You have another call.
Hello, good evening.
Hello, good evening.
Good evening.
Hello.
Good evening, Doc. Good evening,
Thanks
Andre.
for calling.
Hi.
Yes. Okay. I would like to ask, I had a surgery done last year. So after the surgery, I realized one side of my hair, like the left side,
of your...
Well, I had, like, it was trimmed off. I was wondering, what's the reason for that?
One side of where?
My hair was cut off.
Okay.
Yes, I was wondering if that was a reason. And number two, I was wondering if, like, when you have your gallbladder removed, how does your body work? Like, when it comes to going to the washroom, using your bowels.
Okay.
I'll listen over the radio. Thanks.
Thank you.
Thanks.
Okay.
Now, the thing about the shaving of the hair, irrespective of where the hair is, if it is within a certain distance from where you're going to operate, they expect you to shave it so bacteria don't lodge in it, and that you don't cut into the hair itself. So whether it's on your head, your private parts, or your chest, wherever it is, you shave it, so that the field, what we call the field, the area you're going to cut and open, is not hairy.
So that's before the surgery, Dr. Surage?
Before the surgery.
Oh, okay.
Now, generally, if you had planned it, you would have told the person, well, because of that, we may have to shave. Because, for example, when I do surgery of the mastoid, behind the ear, I shave a good 2 or 3 inches behind the ear, all around, like behind, from top of the ear to the back, because that's where I'm going to make the cut, and I don't want, because when the hair is like this, bacteria can lodge in it and infect the process. So that is why. So you shave the hair to give you a good, clear field to which you can operate without causing contamination by bacteria. What was the next question she had again?
About the gallbladder.
Right. The gallbladder is a little bag, The gallbladder itself is a little bag that is on the underside of the liver, hanging in there. And it is supposed to store extra bile that is produced by the liver. So the gallbladder, because it's a storage, sometimes the storage can remain there for long and form stones, and you get gallstones. because any part of the body that has a tube where fluid runs, if that tube is blocked or if that fluid is slow, calcification can happen in it.
But just explain to us, Dr. Surage, if you say the bile stores in the gallbladder, you have excess bile.
Yep.
Where's this bile supposed to go to?
Oh, the bile. Okay. So the bile is formed by the liver, and all the bile is collected in a little tube, and the tube end up in the underside of the liver as a little pouch that collects it. And there is another tube in that same pouch, from the same pouch, that goes to the duodenum. And it is and it enters into the second part of the duodenum, where it goes into the stool. So that is how the liver clears some of the things. And I even remember the name of the little tube where it enters the duodenum, the ampulla of Vata. That's the name. Mr. Vata must have. So when you have gallstones and they're removing the gallbladder, all they remove is that sac. Everything else is running. The only thing is that you don't have a reserve of bile. And secondly, the color of your stool, to a large extent, is determined by the bile.
So just stick a pin there. Just like the appendix, that gallbladder, are you saying that you can survive without it?
Oh yeah, it's just to store extra bile, and sometimes when you eat, it might contract a bit to push some bile into the stool.
But if it's a natural process of passing on excess bile into that sac, the gallbladder, and you don't have that storage facility anymore now, where does the bile go, the excess bile? Because certainly
gradually,
the body...
what it does, the bile gradually collects, and it rather than being collected and stored as bile, whatever is being made goes straight to the duodenum and clear immediately.
So the body finds another way to work around it.
Yeah.
So let me ask you, so then what prevents the bile from going to this duodenum? What happens? Because something goes wrong. That's why you said after a while the bile turns into stones. So something happens that would cause this sac not to function the way it's supposed to pass the bile.
Oh, when it has a stone in it, the stone can get infected.
Oh,
and
the stone is what
so you're not going to remove the gallbladder unless there's a problem with it, and usually it's a stone that's in there.
And the stone is caused by what?
As I was saying before, any part of the body that secretes, and the secretion goes through a tube to be delivered elsewhere, that secretion, if it moves too slowly over too long, calcium can build in it. So you have a kidney stone, you have a bile stone, you have a bladder stone. I have even seen somebody with a stone in the nose.
Wow.
And there are the submandibular gland, the salivary gland can have stones, all of them can have stones.
Wow.
Too much for one night, right?
I guess that's why King David said, I'm wonderfully made. Wow.
Yeah, so
oh my God.
That's how it operates.
And we always tend to think of, right, without the heart you cannot survive, without the liver and your lungs. But I mean, there's so many other important parts of the system which are just as important. It's almost like a vehicle.
Yeah, and you don't fully appreciate its importance until it goes wrong.
Yeah.
Yeah. So I think
yes, we have to wrap up, Dr. Surage.
Well, listeners, thank you very much for participating, and I appreciate your calls very much, and at least it gives us a bit of dialogue. And so thank you very much, and have a wonderful evening next time.
And as we're discovering, our listeners have great questions to ask.
Yeah, I must say the questions are very searching and very legitimate questions. And it's amazing how many have questions they would like to ask but never find the courage to call.
Yeah, because I can only ask so many.
Yeah, of course. Yes, that's right.
I can only ask so many. So I'm very, very happy when our listeners call in with these real searching questions. Yeah.
That's good. It helps the program to expand the knowledge base.
Exactly. Okay, Dr. Surage.
Thank you very much, sir.
Thank you very much for your service, as
No
always. So you've been listening to and viewing Doctor in the House live on REV-UP St. Lucia every Tuesday from 6 p.m. to 7 p.m. So join Dr. Surage again next week Tuesday, same time, from 6 p.m. to 7 p.m. for another Doctor in the House. Brought to you with the compliments of La Place Salaison, Dalkan Pharmacy and Tapio Hospital.
At Tapio Hospital, we operate a 24-hour emergency service for all your urgent healthcare needs. Our qualified medical specialist will be on hand to ensure that you receive the best of care. Call us at 459-2617. Tapio Hospital, where the patient safety comes first.
Looking for affordable, reliable healthcare? Visit Dalkan Pharmacy on Coral Street, Castries, where your health comes first. We carry a wide range of over-the-counter and prescription medications, all at unbeatable prices. Plus, enjoy special discounts on prescriptions for kids 12 and under and seniors 60 and over. We offer supplements, body braces, skin care, feminine care, and oral care items, topical creams, and more. Plus blood sugar monitors for just 40 EC, 50 test strips for only 50 EC, and blood pressure machines at affordable prices. If what you need is currently out of stock, we're happy to place specialized orders just for you. Need advice? Check out our private counseling room. Visit Dalkan Pharmacy on Coral Street, Castries, opposite the Magistrate Court, or contact 572-5282 or 720-1655 for more information. Dalkan Pharmacy, your health is our mission.
It's delicious.
La Place Salaison is the true home of quality meat and deli products, selected and priced to suit every palate and pocket. We sell all cuts of meat, poultry and fish, from tasty lamb necks and succulent pork chops to lean dolphin and juicy top round steaks. Our deli items include turkey, ham, bacon, pork sausages, meat patties, chicken nuggets, deli ham and eggs, so that breakfast or that party is a breeze. And for your added convenience, we sell restaurant essentials and grocery items. So where's your next meal coming from? La Place Salaison, of course. La Place Salaison, Castries, Rosalie, Beaufort, and Soufrière.
It's delicious.
REV-UP St. Lucia is located at Unit 4, Gablewoods Mall, Sunny Acres, Gas-Free St. Lucia. Tune in on 95.9 FM or online at REVUPSLU.com. Call the studio at 572-9710 or WhatsApp 287-0971. Call the office at 572-0383 or 572-0215. REV-UP St. Lucia, the alpha of radio.
For the short term, ease my mind, ease my mind.